Good morning, and thank you for joining our webinar featuring a presentation on Physician Quality Reporting Systems, PQRS. My name is Leah Anderson, and I am the marketing lead at BMS Practice Solutions. Before we get started, I would like to ensure that you have the best webinar experience. At the end of the presentation, we will have a Q&A segment. You will be able to ask questions by either typing them in the questions box or by using the raise your hand feature. I will now begin our webinar with a brief introduction of our company. BMS, headquartered in Upland, California, is the nation's leading provider of revenue cycle management services and web-based practice management software for independent outpatient rehabilitation practices. In fact, we work exclusively with PT, OT, and speech practices. To provide some perspective on our experience and market presence, BMS has been operating for over 20 years. Currently, we provide services and technology to over 500 practice locations in 40 states, and we process over 2.2 million claims annually on behalf of our clients through our RevFlow system. One of our service objectives is to be a local vendor to our clients. In addition to our California office, we serve clients from 5 additional service centers located regionally throughout the United States. At this point, I would like to introduce John Wallace, who will be conducting our webinar presentation today. John Wallace is the CEO of BMS and a founding member of the company. As you most likely know, John is a physical therapist, former practice owner, has been very involved with the APTA over the years, and is a nationally invited speaker on therapist coding, compliance, and related topics. Please welcome John.
Needs for quality-based and value purchase services. In 2013 and 2014, eligible therapists, PTs and OTs can participate through claims-based or registry-based submission. Speech and language pathologists can only participate through ASH's known outcome system. Therapists who work at rehab agencies, also known as ORFs, comprehensive outpatient rehabilitation facilities, outpatient hospital settings, and skilled nursing facilities are unable to participate in the PQRS program, as the UB04 and 873 institutional formats do not accommodate PQRS reporting. So PQRS reporting is only for eligible therapists working in the private practice setting with the designation as a therapist in private practice. In 2011, Congress passed the Patient Protection and Affordable Care Act. This further modified the participation incentives of the PQRS program. So as most of you are aware, if you've been following the PQRS developments, the general plan was to gradually decrease the incentives and to then eventually migrate them to penalties. So that's happening in 2011 through 2014. So for the last 3 years of the program, the incentive payment is only 0.5% of all your allowed charges to Medicare if you participate successfully. In 2015 begins the 1.5% penalty for not participating. Then in 2016 it moves up to 2%. So reporting periods for PQRS, you report during the entire calendar year. Then CMS does their work on the data, and then they report your success and then do checks in August or September of the following year. So it takes about 9 months for them to take the data that are submitted by therapists, and then do all the number crunching, and then announce the successful completion of the program for those who did that. The important thing I think for all of you to know is that 2015 is the compliance year to avoid penalty. Now, what that means, though, is the penalty will be applied in 2015 if you do not attempt to submit PQRS data in 2013. So you don't have to successfully participate in 2013 in that you must make the incentive, must submit data accurately enough to get the incentive, but it does mean you do need to submit data. And you must submit data on each individual therapist's NPI number. Remember that all the submissions for the PQRS program are tied to the individual NPI number of each therapist. It is not rolled up by practices, so practices don't qualify or not qualify based on their tax ID number. It's by each individual therapist. The provisions of the PQRS program apply to physical therapists in private practice, occupational therapists in private practice, and speech therapists in private practice. Also, therapists that work for physicians and other qualified non-physician providers. Part B providers paid by Part A payers are not eligible in 2012, 2013, or 2014. And that's outpatient rehab agencies, again, ORFs, comprehensive outpatient rehab facilities, hospital outpatient, and skilled nursing facilities. Again, it's important to realize that reporting is by each individual therapist's NPI number. So each therapist must qualify individually. To qualify, you must meet the approval percentage on 3 individual measures or on 1 group measure. There is only 1 group measure that applies for PQRS for rehab, and it only applies to PT. Incentives or penalties will apply to each therapist individually. Measures are not rolled up by practice, and each therapist does not need to use the same 3 measures or the group measures. So your practice does not have to have every therapist using the same measures in order to qualify. Each therapist must report successfully on 3 individual measures or a group measure. So the reporting period for 2013 is the entire year, January 1 through January 31, 2013. The incentive bonus applies to all Medicare allowable payments for dates of service that occurred in the reporting period. So your 0.5% bonus would be 0.5% of your total allowable Medicare charges for the year by therapist. So there have been some changes for the individual measures in 2013. No significant changes for the PT measures. Well, I guess that's not actually true because they dropped the one for using electronic health record. And they've added several measures for OT, so 9 apply to OT. So this webinar will focus on the PT and OT measures that are most common in the outpatient orthopedic setting. We will also talk briefly about the group measure for back pain, which is available to physical therapists. Remember that measures apply for speech and language pathology through the NOMS registry through ASHA. The lump sum payment of 0.5% for allowed charges will be made in the 3rd quarter of 2014. Payments will be made to the holder of record of the tax ID number associated with the practice. So the check will come, just like all of your Medicare payments come, to the group number tax ID number. The Medicare administrative contractors will be posting participation information and reports, and these are available to providers on their websites, but it's also going to be available on Medicare Compare. And they're saying that you should be able to actually look during the course of the year into Medicare Compare and actually see your progress towards your PQRS participation. So there's 2 types of reporting, and this can be a little confusing, so I'll try to be as clear as possible. There's claims-based reporting, which is part of the billing process. So in claims-based reporting, you report the quality data codes on the same day that you provide the qualifying service. So in most of the measures, those are the PT and OT evaluation and reevaluation codes. There's a couple of exceptions to that, but that's not important for this part of the discussion. So on the day that you submit your charges for the services you delivered, you must submit the quality data codes. You can't submit them the next day. You can't submit them a week later. You gotta submit those the same time you select the CPT codes that you're going to bill with. Registry-based reporting is through a CMS-approved registry. So there's more relaxed reporting requirements in that the quality data measures don't need to be submitted at the same time as the qualifying CPT codes do for the charges rendered that day. However, the percentages that you have to hit are significantly different between the claims-based and the registry-based. So again, claims-based, the quality data codes must go into Medicare on the same day as the qualifying service codes you're billing for. In registry, they do not have to. So the two reporting options are the same in that you must report successfully on at least 3 individual measures. If you're submitting claims-based, then you have to, in order to qualify for successful participation, you must hit at least 50% of the opportunities you have to use the measure. If you're using registry-based submissions, then you have to hit 80% of the eligible patients. So the trade-off is for claims, you have to submit them to quality data codes on the day you submit your bill, but you only have to do it half the time. With registry-based, because the reporting requirements aren't linked as tightly, they're requiring you to hit a larger success number at 80%. The percentage is actually calculated by taking the clinical actions that are described by the measure and then dividing that by the eligible patients as defined by the measure number. So the clinical action described by the measure is in the denominator section of each quality data code, and the eligible patients are in the numerator section. So we'll look at that more closely in a moment when we look at some of the individual measures. Now, if you do the group measure for back pain, and again, this applies to PT only, the group measure for back pain is actually 4 individual measures that are rolled up into one measure, and you can use one code to report on those. You have to hit the 50% mark if you do claims-based, or you have to hit the 80% mark if you do registry-based reporting. Now, you have to have for sure a minimum of 15 individual low back pain episodes per reporting therapist for this measure. So that's a challenging number for most practices to hit per therapist. So they might have 1 or 2 therapists in a practice if they saw all the Medicare low back pain patients that they could qualify, but it may be difficult for you to have each therapist qualify for this individual measure. Now, also remember that you can report on more than 3 measures if you want, and you can report on more than 3 measures and report on the group measure for back pain. So if you want to hedge your bets that you're going to get at least 3, then you can report on more than 3 if you like. So the individual measures are measures 154, the falls risk assessment measure, measure 155, which is the falls plan of care. Remember that 154 and 155 are actually linked. So if a patient tests positive for risk for falls, then you must report on measure 155. Then there's the diabetic foot and ankle measures. So the first one is 126, which is peripheral neuropathy for the neuro evaluation component. And then in measure 127 is the diabetic foot and ankle ulcer prevention evaluation of footwear measure. Measure 128 is the preventative care and screening, the body mass index measure with a follow-up plan of care. Measure 130, which is documentation and verification of current medications in the medical record. Measure 131, pain assessment to initiation of patient treatment. And then measure 182, functional outcome assessment. So let's talk about the individual measure specification elements, because the measure descriptions can be a little daunting the first time you read them. So the measure description is a section in the measure that tells you what you have to measure to use the quality data code. The instructions within each individual measure tell you how to do the measure and how often you need to report it. The denominator is the number of eligible patients based on age, qualifying services, and occasionally ICD-9 codes. Then the numerator is how you report and what code you use. And then the rationale and clinical recommendations about each individual measure. Now, the quality data codes are G codes. Now, that has produced some confusion because many people are referring to functional limitation reporting as non-payable G codes. These are also non-payable G codes. So you'd have to be clear when you're asking questions about or reporting on functional limitation reporting versus the PQRS quality data codes. Now, on our corporate website, we have a webinar that I did previously on functional limitation reporting. So if you're not up to speed on that, you can certainly go and listen to that recording of that webinar. Remember that the G codes for the PQRS measures are specific to each measure, and they're specific to the action performed by each therapist. And for those of you who are doing your own billing, you do not apply the GP, GO, or KX modifiers to the quality data codes. If you do that, they will not be counted properly. So there were some changes to the quality data codes for 2013. So if you were reporting on some of these codes in 2012, some of the G codes have actually changed. So, and one measure was actually dropped. So measure 124 for the use of electronic health record was removed from the quality data code set. And measure 128, which is the body mass index measure, they added code G8938, which is BMI calculated but patient not eligible for follow-up. Again, the actual definition of what that means is in the measure itself. Measure 131 pain assessment, they added code G8939. Pain assessment documented, follow-up plan not documented, patient not eligible or appropriate. And then measure 182, functional outcome assessment, added code G8942, which is documented functional outcome assessment and care plan within the previous 30 days. Okay, so let's talk about the group measures for back pain. So you have the options of reporting on the back pain group measures rather than reporting on 3 individual measures. This group measure actually incorporates 4 measures on each individual patient. The measures 148 through 151, which is the back pain initial visit, back pain physical exam, back pain advice for normal activity, and 151, back pain advice against bed rest. So successful reporting is dependent on the number of eligible patients you provide. So there's a formula for looking at that, but the minimum is 15 per individual therapist. Okay, so we are going to actually go through and look at the individual measures, and if there's questions during the Q&A on the back pain measures, we can certainly look at those. Okay, my mouse has disappeared. Okay, sorry about the slight technical difficulty there. So let's go through the individual measures. So measure 126 is the diabetes, diabetic foot and ankle, peripheral neuropathy evaluation, neurological evaluation. So you'll see that all the sections in these codes are the same for each measure. So you see the description of the measure. In this case, it's for patients aged 18 years and older with a diagnosis of diabetes mellitus who had had neurological examination of their lower extremities within the previous 12 months. Now remember, Medicare patients can go down to 18 years of age because people who are on total disability can qualify for SSI and Medicare. Here's the instructions of the measure. So it's once each reporting period. Remember, the reporting period is within the last 12 months. There's a risk categorization system defined here. It says this measure may be performed by non-MD, non-DO clinicians who perform the quality actions described in the measure. Then it talks about the claims reporting and registry reporting, which you've already covered. So for every measure, you want to pay particular attention to the denominator because this defines the set of eligible patients. So in order to be eligible for this measure, the patients must be at least 18 years or older, and they must have a diagnosis for diabetes from the list here. And they have to have a qualifying service. In this case, you'll see the qualifying services are the PT evaluation code and the PT reevaluation code. So this is not eligible for OTs, and also the wound care codes qualify on this measure. So you have to provide this service one time per reporting period, so in the 12-month period of the reporting year, and you can report it during any one of these services, preferably the first one in the year for that patient. But remember, they must have one of the diabetes codes up here. Now, most of the time, you are not treating the patient for diabetes. You're treating the patient for some sequelae related to their diabetes. So your primary your primary PT diagnosis would be the first diagnosis, and then you'd want to have the diagnosis for diabetes on that claim. And it has to not only be on your plan of care, but it must also be part of the claim form. Now, the next section we want to look at is the numerator section. So the numerator section tells you what you have to do and how the codes work. So there's the definition of the lower extremity neurological exam. So, and I won't read that to you. You can look at that on your own. And then there's your choice of your quality data code. So you have the lower extremity neurological exam performed. You would use code G8404, or lower extremity neuro exam not performed for documented reasons. That's G8406, or the lower extremity neuro exam not performed, G8405. Now, one of the things about the PQRS system, which is interesting, is you get credit for reporting the service even if you don't actually do it, as long as you record that you didn't do it. So even though you might not have done it on this patient, if you were to report the G8406 code at the time you did the qualifying service code, which would be the PT evaluation or reevaluation code, or one of the two selective debridement codes, then you would be able to report the code and still get credit for the measure, even though you didn't actually do the measure. So we'll go through each code this way. It'll be a little quicker as we go through it, as you get used to the organization of the individual codes. Okay, here's measure 127, which is the diabetes mellitus foot and ankle ulcer prevention evaluation of foot here. Again, footwear. Again, you see the age is 18 years or older, once per reporting period. The denominator is identical to the previous code for diabetes, and you must have one of these diagnoses here in order to qualify to use the code, and it would be a secondary diagnosis. And again, you must have one of these measures, and this is, again, applies for PT evaluation, reevaluation, and the two selective debridement codes. In the numerator section, they define evaluation of proper footwear. So this includes a foot examination, documenting vascular, neurological, dermatological, and structural biomechanics findings. Foot should be measured using a standard measuring device, and counseling for appropriate footwear should be based on the risk categorization. And then you have the 3 quality data codes that you can report. Measure 128 is the body mass index measure. This applies again to patients who are 18 years or older, who with a calculated BMI in the last 6 months or during the current visit documented in the medical record, and if the most recent BMI is outside the normal parameters, a follow-up plan is documented within the past 6 months or during the clinical visit. So there's a bunch of stuff going on in this measure. So you have to have a reliable way for determining their body mass index. If they're 65 years and older, then their BMI needs to be less than or equal to 23 or less than 30. For 18 to 64, it must be at least 18.5 but less than 25. So the reporting period for this code is within the last 6 months, not the last 12 months. So you know that from the description. Again, we have the information regarding claims versus registry, and then in the denominator section, we see this applies to all patients who are 18 years or older. The patient encounter would be the PT and OT, evaluation codes here. So 97001 is the PT evaluation code, 97003 is the OT evaluation code. So those are the only qualifying visits for this measure. When you look at the numerator, you'll see the definition of body mass index, the calculated BMI, and here's the definition of the follow-up plan. So we get a lot of questions about this. So proposed outline for treatment to be conducted as a result of a BMI out of normal parameters. Now, your patient has probably not been referred to you for weight control. So such follow-up may include, but is not limited to, documentation of a future appointment, education, or referral. So for you, it could be referral back to the primary care physician. We're not likely to do pharmacological interventions or dietary supplements. We may, however, do exercise counseling. So the definition is not eligible or not appropriate for a BMI measurement or follow-up plan. Patient is receiving palliative care. Patient is pregnant, refuses. If there's any other reason documented in the medical record by the provider explaining why BMI measure or the follow-up plan was not appropriate, and the patient is in, or the patient is in an urgent or emergency care situation. That takes us down to the numerator section, and then there's a bunch of choices here. So you can pick that the BMI was within normal parameters and documented, or that it was above normal parameters or below normal parameters, and that you did the follow-up. Remember, the follow-up simply could be a referral back to their primary care physician. Or you have BMI is not calculated, patient is not eligible or appropriate. BMI calculated, patient not eligible or appropriate for a follow-up plan. Or BMI not calculated, reason not given. Or BMI not calculated, or BMI calculated outside normal parameters, follow-up plan not documented. Now, I have had the question a number of times. If for any, the question was, well, I could just say for all the eligible patients that I didn't do the follow-up plan I didn't do the measure for a reason not given. I haven't actually seen an example of this, but I think if you did that every time you saw the patient, that would probably attract someone's attention. And you might get asked for a view of your charts to see if you're just trying to avoid the program. Measure 130 is the documentation of current medications in the medical record. Now, there's some things here that you must pay particular attention to if you're going to do this measure. Again, this applies to all patients 18 years or older. And it's not simply a list, however, of the prescription medications, The list must include all prescriptions, over-the-counters, herbals, vitamins, dietary, and supplements, and must contain the medication's name, dosage frequency, and route of administration. Now, here's an example of something that you see in a lot of the measures. So this measure is to be reported each visit. Now, that's not literally each time you see the patient. It's each qualifying visit. So we'll have to look down in the denominator section to see what exactly they mean by each visit. But the reporting period is 12 months. So if we look down to the denominator section, we can see that all visits occurring within the 12-month reporting period for patients 18 years or older on the date the encounter where one or more of the qualifying CPT codes was listed. So again, it's 18 years or older. Then the qualifying CPT codes are these right here: PT evaluation, reevaluation, OT evaluation, reevaluation, and the cognitive retraining code. And that's primarily in there for the speech pathologists and for the OTs. So both of these things must exist. And remember, each visit only refers to a visit where one of these 4 or 5 services is rendered, not literally every visit. So in the numerator section, they give you the definition of current medications, the definition of not eligible, and that by using the code that shows that the current medications were documented, the eligible professional is attesting the documentation, the documented medication information is current, accurate, and complete to the best of his or her knowledge. So again, you need to capture a lot of information here to successfully do this measure. So all prescriptions, all over-the-counters, all herbals, vitamins, minerals, dietary supplements, each medication's name, dosage frequency, and administered route. So that's a lot of information you have to collect. So a lot of practices are sending these forms out to patients prior to their initial evaluation to try and capture this easily. The quality data codes are down here in the numerator section. We already talked about G8427, which was that the current medications were documented. Then you have the current medications not documented, patient not eligible, or current medications with name, dosage frequency, route of administered, reason not given. So a patient may come in and be able to give you part of this information, but not all of it. Then you would certainly report this G8428 code in those situations. Measure 131 is the pain assessment and follow-up measure. Again, this is a measure that applies to patients who are 18 years and older. And each visit, again, does not literally mean each visit. It means each qualifying visit. We'll look in the denominator to see what visits that actually refers to. So in this particular case, it applies to the PT evaluation code, the OT evaluation code, and the cognitive retraining code. Under the numerator, we see the definitions of the pain assessment. So this is a clinical assessment using a standardized tool for the presence and characteristic of pain. Characteristics may include location, intensity, quality, and onset of duration. Standardized tool is something you need to pay particular attention to. So for the standardized tool, an assessment tool that has been appropriately normalized and validated for the population in which it's being used. Examples for tools include but are not limited to the pain inventory, faces pain scale. There's a whole list here. So you actually need to go out to the internet and download one of these, and then you actually need to follow the standardized testing procedure defined by that particular standardized tool, or this won't qualify as a measure if your records are examined and you're found not to have used a standardized measure that was validated for your patient population. Again, there's a section here on follow-up plan. So the follow-up plan, if the patient's there for pain and that pain is what you're addressing with your therapy services, then your plan of care is your follow-up plan. However, if they're there for something else and they are complaining about a pain in another area that you weren't really intending to treat, then your follow-up plan may be circling back with the referring physician or referral to the primary care doctor. The numerator quality data codes are listed here for you. G8730 is the pain assessment documented and positive and a follow-up plan is documented, or pain assessment was documented as negative, no follow-up plan required, and then your other choices are here, and those have to do with either not being done because they're not eligible or simply not being done. Now, measure 154 is the falls measure, and so the falls measure is a little bit different than the other measures because they require you to report your quality data codes in pairs, and we'll see that in a moment. So they make the point here that this is a two-part measure, which is paired with measure 155. So in other words, if measure 154 comes out positive, then you must do measure 155. So there's two measures there for that patient. Now, if you do measure 154 and they're not a false risk, then you don't do measure 155. You still have to do three measures. So you'll have to have actually four measures that at your disposal if you're going to do the falls measure as one of your measures. So again, it's once per reporting period. The reporting period is 12 months. In the denominator section, you can see that this applies only to patients who are 65 years and older. And the qualifying visit codes are the PT and OT evaluation and reevaluation codes. In the numerator, you see the instructions, so you see the definition of a fall, which is important. Then you have the risk assessment. Risk assessment is comprised of balance and or one or more of the following: postural blood pressure, vision, home falls hazards, or documentation of measures of whether medications are contributing. Then you see the numerator, the quality data codes, and here's what I meant that you have to report in pairs. So if the falls risk assessment for falls was completed, then you would report the CPT2 code 3288F, which means that the falls risk assessment was documented, and you would also report 1100F, which is the patient was screened for future falls versus documentation of two or more falls in the past year, or any injury from a fall in the past year. So that would be a positive test there. Then you have the not completed for medical reasons. And then if the patient's eligible for the measure because the patient has documented no falls in the last year, then you report this code. And again, you can see as you read down the list, all the code possibilities are there. So there are generally two codes reported on this measure, and there may or may not be a modifier required in this measure. So 154 is one of the more complicated measures. Measure 155, again, is part of the falls plan of care. So this is, again, part of a two-part measure. So if they test positive for risk for falls in measure 154, then you must do measure 155. Again, that's once during reporting period. We'll go down to the denominator. We'll see again that it applies to 65 years and older. All eligible instances where code 1100F, pain screen for future fall risk, documented documentation of two or more falls or one fall with an injury in the last year. So those are the qualifying parameters of the patient. Again, it applies to the measures on visits where you do the PT or OT evaluation or reevaluation. Then in the numerator section again is the full list of codes that you can select, as well as the definitions relative to the measure. So this the plan of care should include consideration of appropriate assistive device and balance strength and or gait training. Now, typically, we would think that if you were seeing a patient for these types of problems, then they would have been referred to you because they are a fall risk or because they have other balance issues. So these things would typically be involved in your plan of care for that kind of patient. The quality data codes are listed here, much simpler than measure 154. This involves this code here, 0518F, and then you're picking the appropriate modifier depending on what the outcome was. Okay, the last individual measure is the functional outcome assessment measure. Now, let me say this about this particular measure. You will all want to do this measure because functional limitation reporting, which is required starting July 1, requires you to use standardized functional assessment tools. This particular PQRS code simply reports that you are using standardized functional assessment tools. So this is like a no-brainer. So if you're doing functional limitation reporting, which I'm assuming you're going to do since you want to get paid for your services after July 1, then you should definitely report this measure. Now there's a little confusing things about the language here. So here's the description. So 18 years or older with documentation of a functional outcome measure assessment using a standardized assessment tool. Now, it says each visit. Now, this, again, only refers to those visits which are defined in the denominator of the measure. It's not literally each visit. Also, you must report these measures at least every 30 days. Again, this is consistent with the functional limitation reporting requirement. However, if you do a qualifying CPT code before the 30 days is up, then you want to report this code, which says that you had a qualifying service that you did, but it was within 30 days of the previous time you delivered the measure. So you would report G8942 in that particular instance if you have to do like a reevaluation within the next 30 days after doing the evaluation. So let's look at the denominator. This applies to all patients, Medicare patients 18 years or older. But when they say each visit, the visit means either the PT evaluation or the reevaluation. So when it says each visit, it's only each visit where you do one of these services. Now, if you do a reevaluation within 30 days of doing the evaluation, then you're going to report this G8942 code, which says, yes, I had a qualifying service, but it was in 30 days. Otherwise, you come down here to the numerator section, and you are going to report the quality data codes. So now, one of the things that has people a little bit confused is although you're using a standardized tool for pain measures are not functional outcome measures. So they make the point here of saying the use of a standardized tool assessing pain alone, such as a visual analog scale, does not meet the criteria for functional outcome assessment standardized tool. So they have a definition here. They define current, they define functional outcome deficiencies, and again, they define the plan of care. Now, typically, this is not going to be an issue for you because if you are giving a functional outcome assessment tool to a patient, I would assume you'd be addressing any deficiencies identified by the tool. So your plan of care for therapy services is actually your plan of care for fulfilling this particular measure. When you look at the numerator, the quality data codes for reporting satisfactorily, you can see there is the functional outcome assessment and care plan documented, which is G8539, or functional outcome assessment documented, no functional deficiencies identified, plan of care not required. So that's G8542, or functional outcome assessment of plan of care documented within the previous 30 days, and that's G8942. We already talked about that code. Then you have the functional outcome assessment not documented, patient not eligible. Functional outcome assessment not documented, reason not given. So, given that we have to report functional measures starting July 1 for functional limitation reporting, you should definitely consider utilizing this measure. Now, I want to just briefly look at the group measure for back pain, and then we'll be able to take some questions. Okay, so here is the group measure for back pain. And if you look in the CMS documents, this is actually under measure 148, which is the first measure. So the PQRS measures in the back pain group include 148, 149, 150, and 151. That's back pain initial visit, physical exam, advice for normal activities, and then advice against bed rest. Then there's the instructions for reporting. Now, if you're going to report the back pain measures group, you must flag notify Medicare by filing this particular code, G8493, for each, only once in the year on the first patient you're going to report on. You don't have to report it again. You only have to report this G8493 code one time. So you are required to report on 20 unique Medicare patients for this measure, or you can do more. And the patients must be between the ages of 18 through 79, or patients 18 through 79 that have specific surgical diagnosis. So they have to either have the ICD-9 diagnosis here, or they must have the surgical diagnosis. Now, typically, as therapists, we're not reporting these surgical diagnoses. We would typically be reporting the ICD-9 diagnosis for back pain. Then the qualifying encounter codes are the PT evaluation and reevaluation code. So the quality data codes for all measures within the back pain group for each patient must be done during the qualifying visit. If you successfully do all the different parts of the measures, of all four measures, then you can report the composite G code, which is G8502. Now, I'm not going to go through each of the individual measures for you on the measures code, but suffice it to say that these are all typically things you would do with a back pain patient. So there's the things of what you must do on the initial visit, which is functional outcome assessments or pain scales, and a lot of different things that you can do here. So again, this is not a hard measure to do, the group measure. The hard thing is being sure that you get 20 individual unique cases per therapist. So unique cases means that you can't have, two of those 20 measures, or two of those 20 visits can't be on a patient coming back for a flare-up of their low back pain. So it has to be 20 unique patients. So before we take questions and answers, we have a free offer for you. And the offer is that if you would like to know if we can actually help you with your billing and collections or with your revenue cycle management, if you're not satisfied with your payment per visit, or you don't think your aging's being worked properly, or you want to find out if it is being worked properly, you can do a free billing and payment scorecard. And you can contact us to set that up. We take a very data-driven approach to that. We're going to look at 6 months of your practice data, and we're going to look at a cross-section of your explanations of benefits and or remittance advice and do a coding profile on your practice. And then we can tell you pretty precisely if you are where you should be for the region of the country that you're in and the types of patients that you're seeing, or if there's some room for improvement. Our RevFlow software, which is our own software, is an end-to-end solution that provides patient scheduling, electronic medical record, as well as practice management tools. And within the electronic medical record, we have very easy to use PQRS tools and functional limitation tools. So if you would like to get a demo of RevFlow and then decide whether you'd like to do a billing and payment scorecard, we'd be happy to do both of those things for you. Now with that, we'll go ahead and take some questions, and I'll turn it back over to Leah to moderate that for us.
Thanks, John. At this time, please feel free to either A, type your questions in the box provided, or you can use the raise your hand feature and I will either unmute your microphone or send you a pin to enter on your telephone if you're using the telephone.
So if there's any questions, please, you can click on the raise your hand button on your GoToWebinar screen, or you can type the question into the question box and we'll read your question and answer it.
John, I have a question from Sandra. How do you determine whether our office uses registry method on a claim or claim data method?
Well, you would actually have to sign up with a registry. So the most common registries are photo. So if you're a photo customer, you can report your PQRS through photo. And photo also has its own set of unique measures, which are risk-adjusted measures by body part. Now, if you're a WebPT customer, they also have PQRS available in their electronic medical record application, and you can submit registry through WebPT. Now, registries typically charge you to submit your quality data codes. If you do claims-based, then you can do that on your own. You don't need the help of a third party to do that. But to do a registry, you do need to sign up with a registry. Are there any other questions?
John, it doesn't look like there's any more questions. I think this will end our webinar presentation. We thank everyone for joining us. If you do have any questions that come up in the week or so, please feel free to email me at landerson@bmsemail.com and I will get your answers to your questions as soon as time permits. Again, thank you for joining us, and this concludes our webinar.